First and foremost is any time a patient is being selected, these are the key words which have been there for a long time. You don't want to select a patient too early or you don't want a patient too late. So that's a dictum which we have always followed. And not just for this lesion but for any bad lesion. Now, a review of the phenotypes which you saw in the morning. So you have this primary TR, you have the secondary TR, and then you have the lead-related TR. So primary TR is primarily leaflet issue, and then you have congenital and you have the acquired ones. Secondary, you have the ventricular as well as the atrial type of TR. So you have to separate out, and it's got its own implications. Then of course, as far as the lead is concerned, we have this early small discussion. So to find out every time there's a TR and if there's a lead there, the idea to do a 3D is to find out whether the lead is impinging on the leaflet and causing the TR, or whether it is another mechanism where the lead is not related to the TR, but it is just there as a bystander. Now, we also, apart from look at these other things, we look at the symptoms inside. So these are just a brief overview. So we look at various parameters, look at the symptoms in terms of general, cardiovascular, renal, and hepatic. A lot of congestion is going to take place, and then we're going to be especially careful about it. And this is the clinical side of it. And then this old, again, saying of TR begets TR. So once TR increases, the RARB dilatation happens, and then the annulus dilates, and then you have the TB triggering, and then again the TR increases. So over a period of time, the TR starts to worsen, and then we're looking at subjective symptoms, heart failure symptoms worsening, the quality of life worsening, and objectively the dysfunction, and then the renal and liver dysfunction worsening, and the 6-minute walk is look at the effort total. So these are the parameters where we're trying to find out where at which point clinical timeline this patient is there. Now, a brief overview of optimal medical therapy. So this is just from one of the publications which came out this year, and then they had an overview of some registry data. So the first line therapy is always going to be the loop diuretics and the IV in terms of acute presentation. And in terms of acute heart failure registry, they found that 30% had moderate to severe TR, and half of them improved with good decongestion. And in terms of TR versus MR, so the diuresis responded better with TR. And in terms of diuretic resistance, so there was reduced loop effectiveness over a period of time, and then escalation is required and we need additional supplements in terms of thiazide, stromides, and the SGLT2 inhibitors. And MRSA is when the potassium supplementation is needed, and then again between torsemide and furosemide, not much of difference over there. Now, as far as risk stratification is concerned, whenever there's severe TR, so we look at the three areas, broad areas. We look at the clinical assessment, look at the age, older the age. This is about the clinical is about in-hospital mortality. So look at the age, the effort tolerance, and the amount of the diabetes that are needed. And in terms of labs, the amount of eGFR which is going down, the antiproton going up, and then the bilirubin going up, and then again the anemia, and then the peripheral signs. And in terms of echo, you have these important parameters, STAPS-A, FAC, and then the free wall strain, the 3D RBF, and then of course the coupling parameters. And then MRI in case if there is a need for looking at the volumes. RA area is also important, so it's a very low hanging fruit, very easy to do good this one. So anytime if it is more than 32, that means the patient is going down a lane which you don't want to. And then of course the invasive hemodynamics, so this is looking at 2-year mortality. Now in terms of numbers, RV function, so this is just a suggestion for one of the publications last year. So you have an extreme cutoff. You have a TAPS-A of less than 10, you have a FAC of less than 30, and a TDI of less than 6, and an RBF of less than 35, and a strain of less than 14, and the TAPS-A PSP coupling. So anytime you have less than this severe dysfunction, so that means this patient is really in a palliative pathway. So that's why these numbers need to be looked at very carefully. And this is just a hypothetical sort of scenario where what would be the sweet spot where the best time to do it. So the green dotted line is where the benefit comes, and that's where the red arrow is looking at it. So that's where the convergence happens. So that's the time where you have to intervene before the RB function starts to decline, and that's the time the TR should not increase beyond the acceptable limits. And also when the comorbid burden starts to increase. So the idea is to hit the sweet spot, and then the maximum therapeutic benefit is C. and in terms of preserved or moderate RV dysfunction, and then manageable comorbidities. But once they pass that stage, then it's more of a palliative treatment, and this is more of reducing hospitalization, reducing symptoms. Now, when it comes to TT, so the idea is how to use TT as a tool. So looking at severe TR on TT, symptoms no, so then keep on monitoring. Symptoms yes, optimize medical therapy, and then if it is primary and it goes to the heart team, so, and if it is secondary, again look at the underlying cause, treat, and then if no treatment, if it is responding, go back to clinically monitoring. If not, like intervention over there. So this is a broad pathway. Now, in terms of surgery versus transcatheter, so this is a combination of both the ACC as well as ESC. So this is the 2025 and the 2020. So you can look at the TR. So where you have the left heart surgeries over there, and then you have the class 1 over there, symptomatic, again class 1 here. And then at this point, you have right heart failure, so more progressed time here. And then you have the tricuspid valve surgery 2A here. And then you have the RV dilatation. So this is where the echo comes in terms of looking at the RV size, looking at the PA pressure, looking at the dysfunctions, and both LV as well as RV. And again here it is 2A. And then with prior left heart surgery, and again without elevated PA pressure, and then no significant RV dysfunction, surgery is looked into. And then on the other side, you have the asymptomatic pathway, and then you have the primary TR, and then you have the progressive pathway, and then you have the surgery on this side also. So you have the class 2A and the class 2, and then the surgery at this extreme is class 1. Now, as far as TV surgery is concerned, so again, confirm the severity of TR. We have so many parameters available, not one parameter to decide. Look at the annular sizes, there is still standard one. So if there is a high discrepancy, too short, too tall a person, so again use the 21 millimeter per meter squared indexing the body surface area. And especially important to look at RV dilatation. As the RV keeps on dilating, so that means that you are going into a situation where you need to take a decision. And if you need to look at the end diastolic volume, you can look at the CMR. And the decreasing RV function, the parameters which I pointed out earlier, and then RA dilatation and the IVC per torah tells you what is happening. And of course, the PA pressure worsening also. So this is a combination of both the societies and then looking at the various ones. So put it in a very different way. But what's important here is in the 2025, they bring in the TTVR and if symptomatic despite optimal medical therapy, and in high-risk patients without severe RV dysfunction, it comes into class 2A here. And then of course, there should not be any precapillary pulmonary hypertension. And what about the risk scores? So you have these various risk scores that are available. So the most widely used the STS tricuspid, and you have those numbers over there. So you will have to keep those numbers. So these are online calculators which are easily available. So more than 8 for STS, and then you have the tri score. So again more than 6 for surgical, and the TTVR it is slightly higher, and then the tri-valve score. And in terms of prediction, so it's again looking at morbidity, mortality as far as the STS is concerned, very well validated. And the others are again in hospital mortality and hospitalization. The quad, again, the data from the STS is very high, so very well validated, and a high number of patients and highly validated. And in terms of the variables, you have a lot of variables compared to the other two scores, so you have 35 variables here. And the numbers which I showed earlier, and the validation in terms of surgical risk stratification. And in terms of best use, again surgical versus transcatheter versus medical therapy, the STS stands out. And then again you have the tri-score and then the tri-valve, especially for the TTVR. Now as far as the patient selection, transcatheter, so again you had an earlier where you spoke about it. So again you have this pathways here, so you have a primary TR and then you have a secondary TR. And then you have the various pathologies here, and based on that you choose the TTVR and then TR depending on the structural challenges. And again the CID here and the lead positioning, you do these options which are available, and then you have non-resolving TR in terms of the lead, despite the position, then if the lead fits okay, you go back to TTR. On the other side, you have secondary TR, so annuloplasty, not done here, but again that's an option that is available. And then you have the extreme ones, the ones which are really sick, and there's not much you can do, where you have the cable valves at the end point, more of a palliative one. Now TTVRs versus TTR. So what are the pluses and minuses? So here you have TR you have the leaflet issues, you have these numbers, and then you have the jet location, and that makes those requirements need to be looked into. And as far as TR is concerned, there's no mortality, and then in terms of basic requirements, almost nil, and then, but the only problem is there's always going to be residual TR, and this might increase over a period of time. On the other hand, TTVR is limited by the annulus sizing, so it's important not to have a big annulus, and the TR is almost completely eliminated. And then the mortality is slightly higher, and then a risk of need for pacemaker is quite high, and the durability is much more. So these are the pros and cons of both the procedures. As far as annuloplasty is concerned, again it's the size of the annulus, and then you keep looking at it in terms of how big the annulus is, the complicating factors, and you look at the in terms of the H to H, you have these numbers over there. So you have these pluses and minuses, and you have these advantages over there. So you compare both these, and then based on that, the decision is taken either to go for an H to H or annuloplasty. But for us, it is what is available now is H to H repair. Now, the key criteria for device selection, so you have something which is favorable, and then you have something which is intermediate, and then you have unfavorable. I'm not going to go through all of them, so there's more like a revision of all the numbers which you've already gone through. But the leaflet approximation, as you can see here, it has its own table, so these are widely available. You can just look at it and then use this comparison and decide which is favorable, which patient is favorable, and which is unfavorable, and the intermediate one. Now, the factors which are affecting the device choice. So this is where the RV dysfunction and the pacemaker lead, which is there. So this is the red line which is going down here, and then if, based on anticoagulation issues, and then if there is damage to the surrounding structures which are there, and then future procedures that are going to be planned, the durability of the valve and the safety. So all this is considered, and then based on this, the valve or the coaptation device or the annulus device is chosen. Now, so overall, so putting everything into perspective, so this will be the treatment approach, looking at both the anatomical and the pathophysiology. So you have the primary TR, and then you have the secondary TRs, and then you have the complex leaflet pathologies, and then you have the orthotopic, heterotopic, and then if the lead induced, if the TR persists, so you have a extraction over there, and the TR persists, you can look at H2H repair, and then coming out of this side, you can really see these numbers over there. And then at the extreme end again, emphasizing that you have this heterotopic valve, which is really the last resort which is used. And these are the green and the yellow areas, very familiar to all of us, depending on what the situation is. So you have the repair on one side, the replacement on the other side, what is favorable, what is unfavorable. So we have the in-betweens, and then those are the ones. So you can look at it in multiple ways, and again, repair versus replacement. And a brief look at the in terms of comparison of transcatheter versus surgical. So TTR showed lower in hospital mortality and lower pacemaker implants and more reinterventions. So otherwise they were on par, so except for this few ones. And then you can see that over a period of time the curve over there. So initially you see that the number of risk increases with the red line of surgery, but after some time they join together, merge together, and they continue like that for 24 months. So to conclude, to come to the last few ones, just to mention, so one has to look at the primary disease, and then you have the cycle which is there, look at the pathophysiology, look at the anatomy, the remodeling that takes place, look at the pressure, the volume overload, and how the TR happens, and then based on this, you have the right heart failure that's happening, and then you take a decision whether it's a surgery or TTVI. So this is just an overall bird's eye view of what's happening and how you take a decision. And then you have this therapeutic window. So the keywords are too early, too late. So it's always a challenge. It's not so easy. So there's still a lot of areas where still no real answers are there. So to look for the therapeutic window, where that's the ideal time. So based on that, one looks at the different procedural pathways. And then I'd like to sort of close with this. So if one is going to look at the diagnostic workflow, so there's just one. It's not a guideline recommendation, but I think I thought it would look practical. So you start with the severity assessment, subjective assessment, and then look at the objective assessment in terms of the echo, and then clinical surveillance, and then you bring in the scores here, and then decide low surgical risk surgery first, high surgical, you go to the transcatheter, and again looking at the anatomical and pH assessment, you look at the various options that are available, and then discuss with the patient, and then the intervention is done. And I will close with this slide. So these are the studies which are going on, and there's still many areas which the data is still not fully available. Each one of us might have our own opinion about how to go about doing it, but these are the trials which are going to come, and it's more like a summary what I've sort of gone through, and like to end with this. So, intervention, too early, too late, who, what, when. Thank you.